The standard edition of the complete psychological works of Sigmund Freud, Volume 1, Hysteria, 1888. Editor's note: the present translation by James Strachey seems to be the first into English. In two of Freud's letters to Fliess, published in the Anfang, 1950a of May 28, Letter 4, and August 29, Letter 5, both of 1888, and by implication in a third of November 24, 1887, Letter 1, he speaks of his contributions to Villaret's Encyclopedia, a work published in two volumes, 1888 and 1891. Since the articles in Villaret are unsigned, it is not possible to be completely sure of their authorship. Freud himself specifies only one of them in these letters, that on cerebral anatomy, and complains that it has been very much cut down. But in his autobiographical study, 1925d, he further mentions an article on aphasia, standard edition, volume 20, page 18. The editors of the Anfang suggest, in addition, that articles on infantile palsies and on paralyses might be attributed to him, and with more conviction include, as probably by Freud, the one on hysteria which follows below. Footnote 1. Another very much shorter article on hysteroepilepsy is less obviously by Freud, though a footnote to it seems most likely to be his. We have included this article in an appendix below, page 58. The 1953 reprint of this article in Psyche, the Stuttgart periodical, is preceded by a short paper by Professor Paul Vogel, which gives an admirable and convincing summary of the arguments for believing that the article is in fact by Freud. No one who reads it in relation with Freud's contemporary writings can feel doubt as to its authorship. Footnote 2. The one possible question is raised by an apparent misrepresentation of Charcot's views on page 42. Apart from a whole series of duplications of views expressed by Freud elsewhere in his signed works, there is one particular point which seems conclusive. This is a passage towards the end in which the cathartic method of treatment is explicitly described and is attributed to Breuer. At this date, 1888, Breuer's method had not been published either by himself or by anyone else. Its first publication was in Breuer and Freud, Preliminary Communication, more than 4 years later, 1893a. Freud, as he tells us, 1925d, Standard Edition 2019, had long been in Breuer's confidence and had known of his method even before going to Paris in 1885. Thus, Freud's authorship may be taken as established. Footnote 1. Incidentally, this passage serves further to demolish the myth, which is still met with, that the cathartic method originated with Pierre Genet, whose book, which included similar notions, was published in 1889, and so seemed to give him a technical priority over Breuer. The present reference in 1888, which has, oddly enough, usually been overlooked, finally disposes of this claim. But in all this discussion, weight must be allowed to Anderson's view, which is very briefly indicated in a footnote below on page 57. The article as a whole shows Freud still closely following the doctrines of Charcot in his account of hysteria, though quite apart from the reference to Breuer, there are 2 or 3 passages, especially towards the end of the article, in which there are clear signs of a more independent attitude. Hysteria. Hysteria, in the Greek, translated as womb, French, hysterie, English, hysterics, Italian, isteria, feminine, isterismo, male, masculine. 1. History. The name hysteria originates from the earliest times of medicine and is a precipitate of the prejudice, overcome only in our own days, which links neuroses with diseases of the female sexual apparatus. In the Middle Ages, neuroses played a significant part in the history of civilization. They appeared in epidemics as a result of psychical contagion, and were at the root of what was factual in the history of possession and of witchcraft. Documents from that period prove that their symptomatology has undergone no change up to the present day. A proper assessment and a better understanding of the disease only began with the works of Charcot and of the school of the Salpêtrière, inspired by him. Up to that time, hysteria had been the bête noire of medicine. The poor hysterics, who in earlier centuries had been burnt or exorcised, were only subjected in recent enlightened times to the curse of ridicule. Their states were judged unworthy of clinical observation, as being simulation and exaggerations. Hysteria is a neurosis in the strictest sense of the word. That is to say, not only have no perceptible changes in the nervous system been found in this illness, but it is not to be expected that any refinement of anatomical techniques would reveal any such changes. Hysteria is based wholly and entirely on physiological modifications of the nervous system, and its essence should be expressed in a formula which took account of the conditions of excitability in the different parts of the nervous system. A physiopathological formula of this kind has not yet, however, been discovered. We must be content, meanwhile, to define the neurosis in a purely nosographical fashion, by the totality of symptoms occurring in it, in the same sort of way as Graves's disease is characterized by a group of symptoms: exophthalmos, struma, tremor, acceleration of the pulse, and psychical change, without any consideration of the closer connection between these phenomena. 2. Definition. German as well as English authorities are still in the habit today of allotting the descriptions hysteria and hysterical capriciously, and of throwing hysteria into a heap, along with general nervousness, neurasthenia, many psychotic states, and many neuroses which have not yet been picked out from the chaos of nervous diseases. Charcot, on the contrary, holds firmly to the view that hysteria is a sharply circumscribed and well-defined clinical picture, which may be most clearly recognized in the extreme cases of what is known as grand hysteria, major hysteria, or hysteroepilepsy. Footnote 1. See, however, the footnote to the article on hysteroepilepsy quoted below, page 58. Hysteria also covers the milder and rudimentary forms which occur in a series gradually shading off from the type of grand hysterie to the normal. Hysteria is fundamentally different from neurasthenia, and indeed, strictly speaking, contrary to it. 3. Symptomatology. The extremely rich, but not at all on that account anarchical, symptomatology of major hysteria is composed of a series of symptoms which include the following. 1. Convulsive attacks. These are preceded by a peculiar aura, pressure in the epigastrium, constriction in the throat, throbbing in the temples, ringing in the ears, or portions of this complex of feelings. These aura sensations, as they are called, also appear in hysterical patients on their own account or represent an attack in themselves alone. Especially well known is the globus hystericus, a feeling referable to spasms of the pharynx, as though a lump were rising up from the epigastrium to the throat. An attack proper, if it is complete, manifests 3 phases. Footnote 2. Charcot usually specifies 4 phases for major hysterical attacks. See, for instance, sketch C below, page 151, and the preliminary communication, 1893A, itself, standard edition, volume 2, page 13. Charcot is not always so definite, and the 4th phase, the terminal delirium, seems sometimes to be omitted. Confer his differing accounts in works translated by Freud, Freud 1886F, 2, page 212, 4 sharply distinguished periods, and Freud 1892-4, page 135, quote, the whole series of 3 phases, end quote. Returning to the main text. An attack proper, if it is complete, manifests 3 phases. The first, epileptoid phase, resembles a common epileptic fit, occasionally a unilateral epileptic fit. The second phase, that of the grands mouvements, manifests movements of wide compass, such as what are known as salam movements, arced attitudes, arc de cercle, contortions, and so on. The strength developed in these is often quite immense. To distinguish these movements from an epileptic fit, it may be remarked that hysterical movements are always performed with an elegance and coordination, which is in strong contrast to the clumsy coarseness of epileptic spasms. Moreover, comparatively severe injuries are for the most part avoided, even in the most violent hysterical convulsions. The third hallucinatory phase of hysterical attack, the attitudes passionnelles, is distinguished by attitudes and gestures which belong to scenes of passionate movement, which the patient hallucinates, and often accompanies with the corresponding words. During the entire attack, consciousness may either be retained or be lost, more often the latter. Attacks of the kind described are often linked together in a series, so that the whole attack may last for several hours or days. The rise in temperature during them is, in contrast to what happens in epilepsy, insignificant. Each phase of the attack, or each separate portion of a phase, may be isolated and may stand for the attack in rudimentary cases. We naturally come across abbreviated attacks of this kind incomparably more often than complete ones. Of especial interest are those hysterical attacks which, instead of the 3 phases, exhibit a coma appearing in an apoplectiform manner, the so-called attacks de sommeil, attacks of sleep. This coma may resemble natural sleep, or may be accompanied by so great a reduction of respiration and circulation as to be taken for death. There are authenticated instances of states of this sort lasting for weeks and months. In such prolonged sleep, bodily nutrition gradually diminishes, but danger to life is not involved. In about a third of the cases of hysteria, the symptom of attacks, which is so characteristic, is absent. 2. Hysterogenic zones. Intimately connected with attacks, we find what are called hysterogenic zones, supersensitive areas of the body, on which a slight stimulus releases an attack, the aura of which often starts with a feeling from this area. These areas may be situated in the skin, in the deep parts, the bones, the mucous membranes, even in the sense organs. They are found more often on the trunk than on the extremities, and they have a predilection for certain places, for instance in women, and even in men, in an area of the abdominal wall corresponding to the ovaries, in the crown of the head, and the region under the breast, and in men in the testes and spermatic cord. Footnote 1. See the case demonstrated by Freud, page 31 above. Pressure on these areas often releases not a convulsion, but aura sensations. It is also possible to exercise an inhibiting influence from many of these hysterogenic zones upon convulsive attacks. A strong pressure on the ovarian area, for instance, rouses many patients from the middle of a hysterical attack or from hysterical sleep. In the case of such patients, one can guard against a threatening attack by making them wear a belt like a truss, the pad of which presses on the ovarian area. The hysterogenic zones are sometimes numerous, sometimes few, and may be unilateral or bilateral. 3. Disturbances of sensibility. These are the most frequent indications of the neurosis, and the most important diagnostic ally. They persist even during periods of remission and are the more important because disturbances of sensibility play a relatively small part in organic brain diseases. They consist in anesthesia or hyperesthesia and exhibit the greatest freedom in their extent and their degree of intensity, such as is attained in no other disease. Anesthesia may affect the skin, mucous membranes, bones, muscles, and nerves, sense organs, and intestines, but the commonest is anesthesia of the skin. In the case of hysterical anesthesia of the skin, all the different sorts of skin sensation can be dissociated and can behave quite independently of one another. The anesthesia may be total or may affect only the feeling of pain, analgesia, which is the most common, or only sensations of temperature, pressure, or electricity or muscular sense. Only one possibility is not realized in hysteria, an impairment of the sense of touch, while the other qualities are retained. On the other hand, it may happen that pure tactile sensations give rise to a painful impression, aphalgesia. Hysterical anesthesia often attains such a high degree that the most powerful faradization of nerve trunks produces no sensory reaction. In extent, the anesthesia may be total. In rare cases, it may affect the whole surface of the skin and the majority of the sense organs. More often, however, it is a hemi-anesthesia, like that produced by injury to the internal capsule. But it is distinguished from hemi-anesthesia due to organic disease by the fact that it usually oversteps the midline at some point. For instance, that it includes the tongue, larynx, or genitals as a whole, and that the eyes are not affected in the form of hemianopsia, but as amblyopia, or as amaurosis of one eye. Furthermore, hysterical hemianesthesia has greater freedom in the form of its distribution. It may happen that one sense organ, or one organ on the anesthetic side, may escape the anesthesia entirely, and any sensible area in the picture of the hemianesthesia may be replaced by the symmetrical area on the other side. Spontaneous transfert. See below, page 48. Finally, hysterical anesthesia may appear in disseminated foci, unilateral or bilateral, or merely in certain areas, monoplegic, on the extremities, or in patches over diseased internal organs, pharynx, stomach, etc. In all of these relations, it can be replaced by hyperesthesia. In the case of hysterical anesthesia, the sensory reflexes are as a rule reduced. For instance, the conjunctival, stenotatory, and pharyngeal reflexes, but the vital corneal and glottis reflexes are retained. The vasomotor reflexes and dilatation of the pupils through stimulation of the skin are not interrupted, even when it is subject to the highest degree of anesthesia. Hysterical anesthesia is always a symptom which has to be looked for by the physician, since for the most part, even when it is of wide extent and of great severity, it usually escapes the patient's perception entirely. In contrast to organic anesthesia, it must be emphasized that hysterical disturbances of sensibility do not, as a rule, hinder patients in any motor activity. Areas of the skin which are hysterically anesthetic are often characterized by local anemia and do not bleed when pricked. This, however, is only a complication and is not a necessary condition of the anesthesia. It is possible to separate the two phenomena from each other artificially. There is often a reciprocal relation between anesthesia and hysterogenic zones, as though the whole sensibility of a comparatively large part of the body were compressed into the one zone. Disturbances of sensibility are the symptoms on which it is possible to base a diagnosis of hysteria, even in its most rudimentary forms. Disturbances of sensibility are the symptoms on which it is possible to base a diagnosis of hysteria, even in its most rudimentary forms. In the Middle Ages, the discovery of anesthetic and non-bleeding areas, stigmata diaboli, was regarded as evidence of witchcraft. 4. Disturbances of sensory activity. These can affect all the sense organs. They may appear simultaneously with or independently of changes in the sensibility of the skin. These can affect all the sense organs. They may appear simultaneously with or independently of changes in the sensibility of the skin. Hysterical disturbance of vision consists in unilateral amaurosis or amblyopia, or in bilateral amblyopia, but never in hemianopsia. Its symptoms are normal examination of the fundus, absence of the conjunctival reflex, diminished corneal reflex, concentric narrowing of the field of vision, reduction of light perception, and achromatopsia. In the case of the last mentioned, the sensation of violet is the first to be lost. The sensation of red or blue persists longest. The phenomena fit in with no theory of color blindness. The different sensations of color behave independently of one another. There are frequent disturbances of accommodation and false conclusions resulting from them. Objects approaching the eye and moving away from it are seen in different sizes and double or several times. Monocular diplopia with macropsia and micropsia. Hysterical deafness is rarely bilateral, mostly more or less complete, combined with anesthesia of the auricle, the auditory canal, and even of the tympanic membrane. Where there is hysterical disturbance of taste and smell too, it is as a rule possible to find an anesthesia of the regions of the skin and mucous membrane belonging to the sense organ. Paresthesia and hyperesthesia of the inferior sense organs are frequent in hysterical patients. Occasionally, there is an extraordinary refinement of sensory activity, particularly of smell and hearing. 5. Paralyses. Hysterical paralyses are rarer than anesthesia and almost always accompanied by anesthesia of the paralyzed part of the body. Hysterical paralyses are rarer than anesthesia and almost always accompanied by anesthesia of the paralyzed part of the body, whereas in organic illnesses, the disturbances of motility preponderate and emerge independently of anesthesia. Hysterical paralyses take no account of the anatomical structure of the nervous system, which, as is well known, shows itself most unambiguously in the distribution of organic paralyses. Footnote 1. This section corresponds to the main topic of Freud's French paper on the comparison between organic and hysterical paralyses, 1893c, probably written for the most part in the same year as this article, 1888, though not published till 5 years later. See page 157 below. Hysterical paralyses take no account of the anatomical structure of the nervous system, which, as is well known, shows itself most unambiguously in the distribution of organic paralyses. Above all, there are no hysterical paralyses which could be equated with peripheral, facial, radial, and serratus paralyses, that is, which comprise groups of muscles or muscle and skin combined in the way which is determined by a common anatomical innervation. Hysterical paralyses are only comparable with cortical ones, but are distinguished from those by a number of features, for there is such a thing as a hysterical hemiplegia, in which, however, only the arm and leg on the same side are involved. There is no such thing as hysterical facial paralysis. At most, alongside of the paralysis of the extremities, there may be a spasm of the facial muscles and of the tongue, situated sometimes on the side of the paralysis and sometimes on the opposite side, and manifested, among other things, by an excessive deviation of the tongue. Another distinctive characteristic of hysterical hemiplegia lies in the fact that the paralyzed leg is not moved in a circular wheeling motion at the hip, but is dragged along like a lifeless appendage. Footnote 2. Confer an enlargement of this point in a footnote to the French paper just quoted, page 163, note below. Hysterical hemiplegia is always linked with a hemianesthesia, which is usually of a comparatively severe degree. Furthermore, in hysteria, we meet with paralysis of an arm or a leg independently, or of both legs, paraplegia. In the latter case, paralysis of the bowel and of the bladder may accompany the anesthesia of the legs, and the clinical picture may consequently come closely to resemble a spinal paraplegia. The paralysis, again, instead of extending to a whole limb, may affect sections of it, a hand, shoulder, elbow, etc. In this, there is no preference for the terminal portion, whereas it is characteristic of an organic paralysis that it is always more pronounced at the distal portion of the limb than at the proximal portions. In the case of a partial paralysis of a limb, the anesthesia usually observes the same limits as the paralysis, and is circumscribed by lines which are at right angles to the longitudinal axis of the limb. In hysterical paralysis of the legs, the triangle of skin between the gluteal muscles corresponding to the sacrum escapes anesthesia. In all these paralyses, the phenomena of descending degeneration are absent, however long the paralyses may last. There is often a high degree of muscular flaccidity. The behavior of the reflexes is inconstant. On the other hand, the paralyzed extremities may atrophy, and indeed they succumb to an atrophy which develops very rapidly, soon comes to a stop, and is accompanied by no change in electrical excitability. To the paralyses of the limbs must be added hysterical aphasia, or more correctly, dumbness, which consists in an inability to produce any articulate sound or even to carry out unvoiced speech movements. It is always accompanied by aphonia, which also occurs by itself. Ability to write is retained in such cases and even increased. The remaining motor paralyses in hysteria cannot be related to parts of the body, but only to functions, e.g., astasia and abasia, inability to walk and to stand. This occurs while the legs retain their sensibility, their coarse power, and the capacity for performing any kind of movement when in a horizontal position, a separation of the functions of the same muscles which is not found with organic lesions. Footnote 1. This precise point is made in the French paper, page 164 below. All hysterical paralyses are distinguished by the fact that they may be of the greatest severity, but at the same time be sharply restricted to a particular part of the body, whereas organic paralyses, as a rule, extend over a larger area as their severity increases. Footnote 2. For this too confer the French paper, pages 164 through 5 below. 6. Contractures. In the more serious forms of hysteria, there is a general tendency for the muscular apparatus to respond to slight stimuli by contracture, diathesis de contracture. The mere application of an Esmark bandage may be enough for this. Contractures of this kind also occur frequently in less severe cases, and in the most various muscles. In the extremities, they are characterized by their excessive height, and may occur in every position, not explicable by the stimulation of particular nerve trunks. They are uncommonly obstinate, do not, like organic contractures, relax in sleep, nor can their intensity be changed by excitation, temperature, etc. They only yield in the deepest narcosis, and after waking reestablish themselves at their full height. Muscular contractures are very frequent in the other organs, sense organs, and intestines, and in a number of cases, too, constitute the mechanism by which function is suspended in paralyses. The tendency to clonic spasms is also much increased in hysteria. 7. General characteristics. The symptomatology of hysteria has a number of general characteristics, a knowledge of which is important both for the diagnosis and for the understanding of hysteria. Hysterical manifestations have, by preference, the characteristic of being excessive. A hysterical pain is described by patients as extremely painful. An anesthesia and a paralysis may easily become absolute. A hysterical contracture brings about the greatest retraction of a muscle of which it is capable. At the same time, any particular symptom can occur, so to say, in isolation. Anesthesia and paralysis are not accompanied by the general phenomena which, in the case of organic lesions, give evidence of a cerebral affection, and which, as a rule, by their importance, put the localizing symptoms in the shade. Next to an absolutely insensitive area of skin, there will be one of absolutely normal sensibility. Along with a totally paralyzed arm, there will be a perfectly intact leg on the same side. It is especially characteristic of hysteria for a disorder to be at the same time most highly developed and most sharply limited. Furthermore, hysterical symptoms shift in a manner which from the outset excludes any suspicion of a material lesion. This shifting of the symptoms is brought about either spontaneously, for instance after convulsive attacks, which often change the distribution of paralysis and anesthesia or suspend them, or owing to artificial influence by what are called aesthesiogenic methods, such as electricity, the application of metals, the employment of cutaneous irritants, magnets, etc. This latter method of influence seems all the more remarkable in view of the fact that a hysterical nervous system offers great resistance as a rule to chemical influence by internal medication, and reacts in a positively perverse manner to narcotics such as morphine and chloral hydrate. Among the means which are capable of removing hysterical symptoms, a special emphasis must be laid on the influence of excitement and of hypnotic suggestion, the latter because it points directly to the mechanism of hysterical disorders and cannot be suspected of producing any but psychical effects. When hysterical symptoms are shifted, some striking circumstances come into prominence. By the use of aesthesiogenic methods, it is possible to transfer an anesthesia, a paralysis, a contracture, a tremor, etc., to the symmetrical area in the other half of the body, transfert, while the originally diseased area becomes normal. In this way, hysteria gives evidence of the symmetrical relation of which, moreover, there are hints that it plays a part in physiological states as well. Just as, in general, neuroses create nothing new, but only develop and exaggerate physiological relations. A further and extremely important characteristic of hysterical disorders is that they do not in any way present a copy of the anatomical conditions of the nervous system. It may be said that hysteria is as ignorant of the science of the structure of the nervous system as we ourselves before we have learnt it. Footnote 1. This is almost a literal replica of the well-known sentence in the French paper, page 169 below. Confer on transfert, page 79 below. The symptoms of organic affections, as is well known, reflect the anatomy of the central organ and are the most trustworthy sources of our knowledge of it. We must for that reason dismiss the thought that some possible organic disorder lies at the root of hysteria, nor must we appeal to vasomotor influences, vascular spasms, as the cause of hysterical disorders. A vascular spasm is from its nature an organic change, the effect of which is determined by anatomical conditions, and it differs from an embolism, for instance, only by the fact that it leads to no permanent change. Alongside of the physical symptoms of hysteria, a number of psychical disturbances are to be observed, in which at some future time the changes characteristic of hysteria will no doubt be found, but the analysis of which has hitherto scarcely been begun. These are changes in the passage and in the association of ideas, inhibitions of the activity of the will, magnification and suppression of feelings, etc., which may be summarized as changes in the normal distribution over the nervous system of the stable amounts of excitation. A psychosis, in the psychiatrist's sense of the word, is not a part of hysteria, though it can develop on the foundation of the hysterical status, and is then to be regarded as a complication. What is popularly described as a hysterical temperament, instability of will, changes of mood, increase of excitability with the diminution of all altruistic feelings, may be present in hysteria, but is not absolutely necessary for its diagnosis. There are severe cases of hysteria in which a psychical change of that kind is entirely absent. Many of the patients who belong to this class are among the most amiable, clear-minded people, with the strongest will, who feel their illness distinctly as something foreign to their nature. The psychical symptoms have their significance in the total picture of hysteria, but they are no more constant than the different physical symptoms, the stigmata. On the other hand, the psychical changes, which must be postulated as being the foundation of the hysterical status, take place wholly in the sphere of unconscious, automatic, cerebral activity. It may perhaps further be emphasized that in hysteria, the influence of psychical processes on physical processes in the organism, as in all neuroses, is increased, and that hysterical patients work with a surplus of excitation in the nervous system, a surplus which manifests itself now as an inhibitor, now as an irritant, and is displaced within the nervous system with great freedom. Footnote 1. The conceptions in this paragraph of the importance of the distribution of excitation in the nervous system are familiar in Freud's writings of this period. See, for instance, the last paragraphs of his introduction to Bernheim, page 83 below. The final sentence here, on a surplus of excitation acting as an inhibitor or as an irritant, appears to foreshadow the principle of constancy. Hysteria must be regarded as a status, a nervous diathesis, which produces outbreaks from time to time. The etiology of the status hystericus is to be looked for entirely in heredity. Hysterics are always hereditarily disposed to disturbances of nervous activity, and epileptics. Psychical patients, tibetics, etc., are found among their relatives. Direct hereditary transmission of hysteria too is observed, and is the basis, for instance, of the appearance of hysteria in boys from their mother. Compared with the factor of heredity, all other factors take a second place, and play the part of incidental causes, the importance of which is as a rule overrated in practice. Footnote 2. The present passage is a pure statement of Charcot's views with his stress upon heredity, his doctrine of the famille neuropathique, and his relegation of all other factors to the rank of agents provocateurs. Only a few years later, Freud was attacking these views, for instance, in his footnotes to Charcot's Le Conte de Maudit, 1892-4, pages 142 and 143 below, in his obituary of Charcot, 1893F, Standard Edition, Volume 3, page 21, and lastly, in his French paper on heredity and the etiology of the neuroses, 1896A, Ibid, page 143, footnote. Returning to the main text. The accidental causes of hysteria are, however, to this extent important that they release the onset of hysterical outbreaks of acute hysterias, as factors calculated to encourage the development of a hysterical disposition may be mentioned. A mollycoddling upbringing, hysteria in only children, premature awakening of mental activity in children, frequent and violent excitements. All these influences are equally prone to bring about neuroses of other kinds, e.g. neurasthenia, so that the decisive influence of hereditary disposition is strikingly shown in this. As factors which produce outbreaks of acute hysterical illness may be adduced trauma, intoxication of lead and alcohol, grief, emotion, exhausting illness, anything, in short, which is able to exercise a powerful effect of a detrimental kind. On other occasions, hysterical states are often generated by trivial or obscure causes. As regards what is often asserted to be the preponderant influence of abnormalities in the sexual sphere upon the development of hysteria, it must be said that its importance is, as a rule, overestimated. In the first place, hysteria is found in sexually immature girls and boys, just as, too, the neurosis, with all its characteristics, also occurs in the male sex, though a great deal more rarely, 1 to 20. Furthermore, hysteria has been observed in women with a complete lack of genitalia, footnote 1, so in the original. And every physician will have seen a number of cases of hysteria in women whose genitals exhibited no anatomical changes at all, just as, on the contrary, the majority of women with diseases of the sexual organs do not suffer from hysteria. It must, however, be admitted that conditions related functionally to sexual life play a great part in the etiology of hysteria, as of all neuroses, and they do so on account of the high psychical significance of this function, especially in the female sex. Trauma is a frequent incidental cause of hysterical illness in two directions. First, by a hitherto unobserved hysterical disposition being aroused by a powerful physical trauma, which is accompanied by fright and a momentary loss of consciousness. And second, by the part of the body affected by the trauma becoming the seat of a local hysteria. Thus, for instance, in hysterical subjects, a slight contusion of the hand may be followed by the development of a contracture of the hand, or, in analogous circumstances, a painful coxalgia may develop, and so on. An acquaintance with these obstinate affections is of the greatest importance to surgeons, whose intervention in such conditions can do nothing but harm. Differential diagnosis of these conditions, especially where the joints are affected, is not always easy. Conditions brought about by severe general trauma, railway accidents, etc., known as railway spine and railway brain, are regarded as hysteria by Charcot, with which view American writers, whose authority on this question is not to be disputed, are in agreement. Footnote 2. Confer for these English terms, page 12, note 2 above. Conditions brought about by severe general trauma, railway accidents, etc., known as railway spine and railway brain, are regarded as hysteria by Charcot, with which view American writers, whose authority on this question is not to be disputed, are in agreement. These states often have the most gloomy and severe appearance. They are combined with depression and a melancholic mood, and exhibit, at all events in a number of cases, a combination of hysterical with neurasthenic and organic symptoms. Charcot has also proved that encephalopathy from plumbism is related to hysteria, and also that the anesthesia, which is common in alcoholics, is not a separate illness but a symptom of hysteria. However, he opposes the idea of setting up such a number of subspecies of hysteria, traumatic, alcoholic, due to plumbism, etc. Hysteria, he insists, is always the same and merely provoked by a variety of incidental causes. In recent syphilis, too, the outbreak of hysterical symptoms has been observed. 4. Course taken by hysteria. Hysteria represents a constitutional anomaly rather than a circumscribed illness. As a rule, first signs of it are probably exhibited in early youth. In fact, hysterical illnesses, even of troublesome severity, are no rarity in children of between 6 and 10 years. In boys and girls of intense hysterical disposition, the period before and after puberty brings about a first outbreak of the neurosis. In infantile hysteria, the same symptoms are found as in adult neuroses. Stigmata, however, are as a rule rarer, and psychical changes, spasms, attacks, and contractures are in the foreground. Hysterical children are very frequently precocious and highly gifted. In a number of cases, to be sure, the hysteria is merely a symptom of a deep-going degeneracy of the nervous system, which is manifested in permanent moral perversion. As is well known, an early age, from 15 onwards, is the period at which the hysterical neurosis most usually shows itself actively in females. This can happen either by an unbroken succession of comparatively slight disturbances, chronic hysteria, or by several severe outbreaks, acute hysteria, separated by free intervals lasting for years. The first years of a happy marriage interrupt the illness as a rule. When marital relations become cooler and repeated births have brought exhaustion, the neurosis reappears. After the age of 40 in women, the illness does not usually produce fresh phenomena, but the old symptoms may persist and strong provocations may intensify the illness even at an advanced age. Males at an immature age seem to be particularly susceptible to hysteria through trauma and intoxication. Hysteria in males gives the appearance of a severe illness. The symptoms it produces are as a rule obstinate. The illness in men, since it has the greater significance of being an occupational interruption, is of greater practical importance. There is something very characteristic about the course taken by the different hysterical symptoms, such as contractures, paralyses, etc. In some cases, the individual symptoms very rapidly disappear spontaneously and give place to others equally transitory. In other cases, all the phenomena are dominated by great rigidity. Contractures and paralyses will often last for years and will then unexpectedly and suddenly pass off. In general, there is no limit to the curability of hysterical disorders, and it is characteristic for a disturbed function, after being interrupted for years, to be suddenly restored to its full extent. On the other hand, the development of hysterical disorders often calls for a sort of incubation, or rather for a period of latency, during which the provoking cause continues to operate in the unconscious. Thus, a hysterical paralysis scarcely ever emerges immediately after a trauma. People involved in a railway accident, for instance, are all able to move after the trauma. They go home apparently unhurt, and it is only after days or weeks that the phenomena are generated which lead to the assumption of a concussion of the spinal cord. So too, the recovery which suddenly sets in usually requires a period of several days for its development. In any case, it may be asserted that hysteria never, even in its most threatening manifestations, involves a serious risk to life. Moreover, complete intellectual clarity and a capacity even for unusual achievements is retained in the most protracted cases of hysteria. Footnote 1. Freud often asserts this in the face of Genet's contrary view. See, for instance, the case of Frau Emmy von N. in Studies on Hysteria, 1895d, Standard Edition, Volume 2, page 104. In any case, it may be asserted that hysteria never, even in its most threatening manifestations, involves a serious risk to life. Moreover, complete intellectual clarity and a capacity even for unusual achievements is retained in the most protracted cases of hysteria. Hysteria may be combined with many other neurotic and organic nervous diseases, and such cases offer great difficulties to analysis. Footnote 2. Not, of course, in the sense of psychoanalysis. Returning to the main text. Hysteria may be combined with many other neurotic and organic nervous diseases, and such cases offer great difficulties to analysis. The commonest combination is of hysteria with neurasthenia. This occurs either when people whose hysterical disposition is almost exhausted become neurasthenic, or when exasperating impressions provoke both neuroses simultaneously. Unfortunately, the majority of physicians have not yet learnt to distinguish the two neuroses from each other. This combination is found most frequently in hysterical men. The male nervous system has as preponderant a disposition to neurasthenia as the female to hysteria. Moreover, the frequency of female hysteria too is overestimated. The majority of the women feared to be hysterical by physicians are, strictly speaking, merely neurasthenic. Furthermore, local hysteria may accompany local illnesses of individual organs. A joint, which is really fungal, can become the seat of a hysterical arthralgia. A stomach with a catarrhal affection can give rise to hysterical vomiting, globus hystericus, and anesthesia or hyperesthesia of the skin of the epigastrium. In these cases, the organic illness becomes an incidental cause of the neurosis. Feverish illnesses usually interrupt the development of a hysterical neurosis. A hysterical hemianesthesia will recede in fever. Five, treatment of the neurosis. This can scarcely be dealt with briefly. In the face of no other illness can the physician perform such miracles or remain so impotent. From the standpoint of treatment, three tasks must be separated: the treatment of the hysterical disposition, of hysterical outbreaks, acute hysteria, and of individual hysterical symptoms, local hysteria. In treating the hysterical disposition, a certain freedom of maneuver is open to the physician. The disposition cannot be done away with, but one can take prophylactic measures to see to it that physical exercises and hygiene are not pushed into the background by intellectual work. One can advise against overstraining the nervous system. One can treat anemia or chlorosis, which seems to lend special support to the tendency to neurosis. Lastly, one can discount the importance of slight hysterical symptoms. One must guard against exhibiting too clearly one's interest as a physician in slight hysterical symptoms and so encouraging them. Serious intellectual work, even if it is exacting, seldom brings on hysteria, though, on the other hand, that reproach may be leveled against education in the better classes of society, which strives towards the refinement of feeling and of sensibility. To that extent, the methods of earlier generations of physicians, who treated hysterical manifestations in young people as naughtiness and weakness of will and threatened them with punishment, were not bad ones, though they were hardly based on correct views. In the treatment of neurosis in children, more can be achieved by authoritative prohibition than by any other method. This kind of treatment, to be sure, will meet with no success if it is applied to hysterias in which the neurosis constantly produces. In the treatment of neurosis in children, more can be achieved by authoritative prohibition than by any other method. This kind of treatment, to be sure, will meet with no success if it is applied to hysteria in adults or to severe cases. In the treatment of acute hysterias, in which the neurosis constantly produces new phenomena, the physician's task is a hard one. It is easy to make mistakes, and successes are rare. The first condition for a successful intervention is as a rule a removal of the patient from his regular conditions and his isolation from the circle in which the outbreak occurred. These measures are not only beneficial in themselves, but also make possible a strict medical supervision, and enable the physician to devote the close attention to the patient without which he will never achieve success in the treatment of hysteria. As a rule, a hysterical man or woman is not the only neurotic member of the family circle. The alarm or tender concern of parents or relatives only increases the patient's excitement or his inclination, where there is a psychical change in him to produce more intense symptoms. If, for instance, an attack has come on at a particular hour several times in succession, it will be expected by the patient's mother regularly at the same time. She will ask the child anxiously whether he is already feeling bad, and so make it certain that the dreaded event will occur. Only in the rarest instances can one succeed in inducing relatives to look on at a child's hysterical attacks quite calmly and with apparent indifference. As a rule, the family's place must be taken by a period in a medical establishment, and to this the relatives usually offer greater resistance than do the patients themselves. The patient's altered perceptions in the sanatorium, the physician's friendly and cheerful certainty, and his conviction, which is soon transferred to the patient, that the neurosis is not dangerous and can be rapidly cured, the avoidance of all emotional excitement, which might contribute to a hysterical outbreak, the application of every kind of strengthening remedy, massage, general Faradization, hydrotherapy. Under all these influences, the most severe acute hysterias, which have led to the patient's total physical and moral derangement, are found to give place to health in the course of a few months. In recent years, the so-called rest cure of Wehr-Mitchell, also known as Playfair's treatment, has gained a high reputation as a method of treating hysteria in institutions, and deservedly so. It consists in a combination of isolation and absolute quiet with a systematic application of massage and general Faradization. Footnote 1. Confer Freud's review of Wehr-Mitchell's book on the treatment of neurasthenia and hysteria, page 36 above. At a later date, Freud recommended a combination of Wehr-Mitchell's rest cure with Brewer's cathartic treatment. Confer Studies on Hysteria, 1895d, Standard Edition, Volume 2, page 267. In recent years, the so-called rest cure of Wehr-Mitchell, also known as Playfair's treatment, has gained a high reputation as a method of treating hysteria in institutions, and deservedly so. It consists in a combination of isolation and absolute quiet with a systematic application of massage and general Faradization. The attendance of a trained nurse is as essential as the constant influence of the physician. This treatment is of extraordinary value for hysteria, as a happy combination of traitement morale with an improvement in the patient's general nutritional state. It is not to be regarded, however, as something systematically complete in itself. The isolation, rather, and the physician's influence remain the principal agents. And, along with massage and electricity, the other therapeutic methods are not to be neglected. The best plan is, after 4 to 8 weeks of rest in bed, to apply hydrotherapy and gymnastics, and to encourage plenty of movement. In the case of other neuroses, for instance, of neurasthenia, the success of the treatment is far less certain. It rests merely on the value of excessive feeding, so far as this succeeds with a neurasthenic digestive tract, and of rest. In hysteria, the success is often magical and permanent. The treatment of individual hysterical symptoms offers no prospect of success so long as an acute hysteria subsists. Symptoms that have been got rid of return or are replaced by new ones. Finally, both physician and patient grow weary. The position is different, however, if the hysterical symptoms represent a residue of an acute hysteria, which has run its course, or if they appear in a chronic hysteria, owing to some special exciting cause, as localizations of the neurosis. To begin with, internal medication is to be disrecommended here, and narcotic drugs are to be warned against. To prescribe a narcotic drug in an acute hysteria is nothing less than a serious technical mistake. In the case of local and resistant hysteria, it may not always be possible to avoid internal medicaments, but their effect is untrustworthy. Sometimes it comes about with magical promptitude, sometimes not at all, and it seems to depend on the patient's autosuggestion or on his belief in its effectiveness. In the case of local and resistant hysteria, it may not always be possible to avoid internal medicaments, but their effect is untrustworthy. Sometimes it comes about with magical promptitude, sometimes not at all, and it seems to depend on the patient's autosuggestion or on his belief in its effectiveness. Apart from this, we have a choice between initiating direct or indirect treatment of the hysterical ailment. The latter consists in neglecting the local complaint and in aiming at a general influence upon the nervous system. in the course of which we make use of an open-air life, hydrotherapy, electricity, preferably by high-tension treatment, and improving the blood by arsenic and iron medication. We have further, with indirect treatment, to consider the removal of sources of stimulus, if any of a physical nature exist. Thus, for instance, hysterical gastric spasms may have as their basis a slight gastric catarrh, while a reddened area in the larynx or a swelling of the terminal may give rise to an unceasing tussis hysterica. Whether changes in the genitals really constitute so often the sources of stimulus for hysterical symptoms is in fact doubtful. Such cases must be more critically examined. Direct treatment consists in the removal of the psychical sources of stimulus for the hysterical symptoms, and is understandable if we look for the causes of hysteria in unconscious ideational life. It consists in giving the patient under hypnosis a suggestion which contains the removal of the disorder in question. Thus, for instance, we cure a tussis nervosa hysterica by pressing on the larynx of the hypnotized patient and assuring him that the stimulus to coughing has been removed. Or we cure a hysterical paralysis of the arm by compelling him under hypnosis to move the paralyzed limb piece by piece. It is even more effective if we adopt a method first practiced by Joseph Breuer in Vienna and lead the patient under hypnosis back to the psychical prehistory of the ailment and compel him to acknowledge the psychical occasion on which the disorder in question originated. This method of treatment is new, but it produces successful cures which cannot otherwise be achieved. It is the method most appropriate to hysteria, because it precisely imitates the mechanism of the origin and passing of these hysterical disorders. For many hysterical symptoms which have resisted every treatment vanish spontaneously under the influence of a sufficient psychical motive. For instance, a paralysis of the right hand will vanish if, in a dispute, the patient feels an impulse to box his opponent's ear, or under the influence of some moral excitement, or of a fright, or of an expectation, e.g., at a place of pilgrimage, or lastly, when there is an upheaval of the excitations in the nervous system after an attack of convulsions. The direct psychical treatment of hysterical symptoms will be considered the best someday, when the understanding of suggestion has penetrated more deeply into medical circles. Or lastly, when there is an upheaval of the excitations in the nervous system after an attack of convulsions. The direct psychical treatment of hysterical symptoms will be considered the best someday, when the understanding of suggestion has penetrated more deeply into medical circles. Bernheim, Nancy. It cannot at present be decided with certainty how far psychical influence plays a part in certain other apparently physical treatments. Thus, for instance, contractures can be cured if one can succeed in bringing about a transfert by means of a magnet. If there are repeated transferts, the contracture grows weaker and eventually disappears. Footnote 1. It should be remarked, however, that Anderson, 1962, 89 footnote, has argued that the account given here of Breuer's therapeutic technique relates only to a specially efficient use of suggestion and does not cover what was to become the essential discovery of abreaction. Returning to the main text. 6. Resume. By way of summary, we may say that hysteria is an anomaly of the nervous system, which is based on a different distribution of excitations, probably accompanied by a surplus of stimuli in the organ of the mind. Its symptomatology shows that this surplus is distributed by means of conscious or unconscious ideas. Anything that alters the distribution of the excitations in the nervous system may cure hysterical disorders. Such effects are in part of a physical and in part of a directly psychical nature. Appendix. Hysteroepilepsy. Footnote 1. Hysteroepilepsy. As explained above, page 39, note 1, this article also appeared unsigned in Villaret, 1888, page 892. Hysteroepilepsy. French, hysteroepilepsy. English, hysteroepilepsy. Italian, hysteroepilessia. In hysteroepilepsy, attacks of general convulsions are observed, as in epilepsy. Footnote 2. Charcot used in earlier days to describe as hysteroepilepsy the severe cases of hysteria, which included in their attacks an epileptoid phase. Since then, he has abandoned this name, which leads to endless misunderstandings, and he now describes such cases as grande hysterie, page 42 above. Accordingly, no special value is to be attached to the term hysteroepilepsy, and one must particularly guard against the view that a special disease combining the characteristics of hysteria and epilepsy is to be understood by it. There are people who are hysterical and epileptic, but in that case, the two conditions exist side by side, one illness as a complication of the other, without any mutual modification. And the attacks of these patients are on each occasion either hysterical or epileptic. Editor's note. The gist of this footnote was repeated by Freud in a footnote which he added to his translation of Charcot's Le Contes de Mardi, published soon after this, 1892-4. It will be found below, page 142. Freud discussed the distinction between hysterical and epileptic fits later in his paper on hysterical attacks, 1909a, Standard Edition, Volume 9, page 234, but at very much greater length in his paper on Dostoevsky, 1928b, Ibid, Volume 21, page 179, footnote. Returning to the main text. In hysteroepilepsy, attacks of general convulsions are observed as in epilepsy. As precursors, there appear a feeling of suffocation, difficulty in swallowing, headache and stomach ache, vertigo, and certain peculiar dragging sensations in the extremities. The patients fall down with a loud cry and are seized with convulsions. They foam at the mouth, and their features are distorted. The convulsions are of a tonic nature to start with, but later clonic. Usually, however, the attack does not come on as suddenly as it does in epilepsy. For a short time, the patients try to fight against the convulsions to save themselves from serious injuries as they fall down and to avoid dangerous situations. An epileptic will even fall into the fire, but that does not occur with hysterics. While the former is pale at the beginning of the attack and later cyanotic, a hysteric's face retains more or less its normal color. Injuries to the tongue from biting are rare in hysteria. In hysteroepileptic attacks, complete opisthotonos often occurs, but not usually in epilepsy. During the attacks, consciousness does not disappear completely, except in the most severe cases. After the attack, a hysteric usually recovers at once. No inclination to sleep and no feebleness remain, as they do with epileptics. On the other hand, visions of rats, mice, and snakes afterwards are not uncommon, and similarly auditory hallucinations. Besides these attacks, all the symptoms of hysteria are found in these patients.